recalling the huge biodiversity of Leishmania, which can infect humans, and more than 20 species written here can infect humans, and they belong to two main complexes, Leishmania and Vienna. And some species are dedicated to the so-called countries of the Old World, Africa, Europe, Asia, and even Australia. And the Vienna complex dedicated to the New World countries, namely the Americas. And only Leishmania infantum can be found on both Old and New World. And this species has been probably important some many years ago. So Leishmaniasis is a vector-borne parasitic infection. And as you know, it is transmitted by female sandflies. And once the host has been bitten, it is also injected with Leishmania promastigotes. And humans are both the host and the reservoir of the disease in the particular setting of India. So in that area, it is an anthroponic disease, while in other areas of the world, it is a zoonotic cycle, a zoonotic disease, where humans are infected, of course, but many other mammals which serve as a reservoir, and the reservoir can depend on the geographical area. In Europe, the dog is the main reservoir, but also other mammals has been identified during some peaks of epidemics, such as hares, foxes, cats, rodents. Rodents are very prevalent as reservoir, for example, in the Mediterranean basin, and notably in northern Africa. Well, let's move now to the life cycle of Leishmania in humans. So after infection, so after a bite by a sandfly, the promastigotes are phagocytosed by our phagocytic cells, which are macrophages, but also dendritic cells and immune effectors. And the parasite has the capacity, the very peculiar capacity to multiply in those immune cells and to survive in a parasitophorus vacuole by subverting the host immune response. So it multiplies and it can reinvade other cells. And this is the manifestation of the disease and the clinical signs. The disease can be located only and remain located to the skin depending on the Leishmania species, and some species can produce only cutaneous infection, while two main species can be responsible of systemic infection, which is called visceral leishmaniasis, and those immune infected cells gain the bloodstream and disseminate to other lymphoid organs, such as the bone marrow, liver, the spleen, and so this is responsible to visceral leishmaniasis. So the clinical presentation can depend on several factors, the Leishmania species, as I told you, but also the immune background of the patient and probably the genetics of the patient, but these genetic factors remain largely unknown to date, although they are highly suspected in some geographic areas. It can also depend on probably malnutrition, particularly in Africa or in India. So depending on those factors, it will produce a visceral leishmaniasis, cutaneous leishmaniasis, and a particular form, which is mucocutaneous leishmaniasis, after a cutaneous infection, where there is a dissemination later mainly to mucocutaneous location in the face. And the severity of infection, as you see here, is variable, with visceral leishmaniasis being lethal without treatment. and mucocutaneous leishmaniasis, leading to very severe prognosis and no spontaneous healing compared to cutaneous leishmaniasis. So a recent very nice study has reported an estimation of European cases. And in Europe, you see here that mainly cutaneous leishmaniasis cases are diagnosed, 76%. Most of them are imported cases. 21% of Leishmania cases are visceral leishmaniasis, and most of them are autochthonous cases, and a small number of cases are also diagnosed with mucocutaneous leishmaniasis. So this is, of course, a partial view of the disease in Europe, as the cases are not always reported. There is no systematic, no mandatory reporting registry, so it's difficult to have a clear estimation. So it's really probably underestimated. Let's start with visceral leishmaniasis, and the severity and the onset of the disease will depend on the immune response of the host, and if the host has a strong Th1 immune response, it can clear the infection and do not develop the disease. So that's why the disease usually leads to a progression of infection if you have a factor of immunosuppression or malnutrition or anything else, or young age. And why do we know that? It's because now we have a more and more sensitive diagnostic tests, particularly based on serology. And for example, in the south of France, a study has shown that in some areas, some villages, about 30% of people have a positive serology, so they have been infected, but they have not developed the disease. So they remain asymptomatic as soon as they have a strong immune response. And there has been also studies conducted in Spain and in Madrid, intramuros. The study has shown that 1% of people screened were seropositive. And when using it's in town, and so there is a lesser chance to be to get infected in a big town. And despite that, 1% of the population was positive, and 8% of the population was positive using a more sensitive test, which is the interferon gamma release assay. It relies on in vitro stimulation of immune cells and the measure of cytokines of interferon gamma released after the stimulation with the specific Leishmania antigens. And in that, using that very sensitive test, they showed that 8% of the population had been in contact with the parasite. So it means that these patients, these people, these subjects, because they are not patients because they are not ill, but these people had been bitten by sandflies and had been previously infected. So, well, the progression of the disease, of course, in those patients which have been infected, they have maybe still dormant parasites somewhere. Some studies have shown that possibly the liver could harbor a dormant parasite, and which could reactivate years after primary infection if the host becomes immunocompromised, for example, during transplantation or HIV infected or whatever. So it could be a disease like, for example, toxoplasmosis, where after infection, you have the lifelong, you have a cyst in your muscles and other organs. And if you become immunocompromised, you can develop a severe disease. Well, immune suppression, is in Europe the main factor for visceral leishmaniasis. Also, we also diagnose cases still in young infants. but regarding adults, so the immune conditions leading to the development of the disease is, of course, AIDS, so HIV, progression of HIV infection, which is well known since decades now. It is of increasing importance in other areas in the world, such as Brazil and East Africa. But in Europe, it's mainly immune suppression due to transplantation, because there is an increasing number of transplantation procedures. So many, more and more immunocompromised patients. And this condition has been more recently acknowledged as a condition favoring leishmaniasis, visceral leishmaniasis. And for an unknown reason, it is most observed in kidney transplant patients. And over immune suppression background can also develop visceral leishmaniasis, such as patients treated with immune suppressors for various conditions, various diseases, such as inflammatory chronic disease. So the clinical signs of visceral leishmaniasis includes intermittent fever, developing some months after infection, usually, and progressive splenomegaly, which is present in more than 80% of cases. Hepatomegaly can be also present in 1/3 of cases, and lymphadenopathy, etc. And there is a dysfunction of the immune system. And with hypersplenism, which leads to a consummation of red blood cells and platelets also, so it can lead to anemia, thrombopenia, and of course, the manifestation can be purpura, epistaxis, so bleeding somehow, either externalized or sometimes internalized. This will finally lead to an altered condition, of course, weight loss and or organ dysfunction with renal failure or hepatic dysfunction. And if the disease, the infection is not treated, it leads to death due to cachexia and superinfection. And you see here the classical picture in infants, but this is also observed in adults. So as I told you, in Europe now we observed more cases in immunocompromised patients. The clinical signs are typically the same, hepatosplenomegaly and so on. But in HIV patients, we also observe skin manifestation, as shown on this picture, with ulceration, even due to Leishmania infantum, and more atypical manifestation, but observed still in 50 to 20% of patients, which are gut localization and lung localization with ulceration in the digestive tract. And in this ulceration, you also find Leishmania parasites. And interestingly, in those patients, the disease can be exacerbated after onset of highly active antiretroviral therapy due to IRS syndrome, immune reconstitution syndrome, because following the onset on antiretroviral therapy, there is somehow a restoration of the immune response, which leads to an exacerbation of the anti-Leishmania response, which was suppressed because the patient was highly immunosuppressed. And there is an exacerbation of the disease. And during that first phase of antiretroviral therapy, the consequences of Leishmaniasis can be very severe. So it's usually recommended to start the anti-Leishmania treatment before the antiviral treatment. So let's move to cutaneous and mucocutaneous Leishmaniasis. which can have different manifestations, either manifesting with dry lesion due to Leishmania tropica, for example, or to Leishmania infantum, as we can see in Europe, and humid and ulcerative lesions. And in this setting, it's the main species in the old world is Leishmania major. But this is also the typical presentation with Leishmania of the New World, such as Guyanensis and Brasiliensis in South America, which is responsible of this ulcerative lesion. Sorry. Regarding mucocutaneous leishmaniasis, the localization is very frequently on the face, and it will occur usually some months or years after an initial infection, which has healed. So, and the secondary localization, usually on the mouth or the nose, appears very at a distant site of the initial site of infection with the bite of the sandfly. The problem is that it can lead to a facial destruction if it is not treated, and the consequences are very terrific. Finally, there is also particular manifestation, which is diffuse cutaneous leishmaniasis. This is due to Leishmania aethiopica in the Old World. It can present as leprosis-like lesions, and there is also a possible evolution to a mucocutaneous leishmaniasis. Well, regarding the diagnosis, there are two approaches, either serology or parasitic examination. The serologic assays are very various. Various methods can be used. It is used mainly for visceral leishmaniasis, but it also can be useful sometimes for cutaneous cases. So the methods on the market are either a rapid diagnostic test based mainly on immunochromatographic tests, which use a recombinant antigen, the RK39. So it is a very rapid test, so well adapted to mass screening. In Europe, it has been, or in Africa, in an endemic setting, it has been evaluated on samples such as serum, urine, saliva. So urine, saliva produce less sensitive results, but there is a high sensitivity on serum, as shown in India. Interestingly, the sensitivity can be lower in other areas in the world, such as Brazil and East Africa, and in a French evaluation study, it showed only 80% sensitivity, so less than ELISA assays, which are mainly used today, because there are several commercialized assays on the market, and they have a sensitivity varying from 80% to 94%. Other tests, such as immunofluorescence or direct agglutination tests, can be also used. And the gold standard, is a Western blot assay, which is highly specific and also highly sensitive. And it has the advantage to confirm positive ELISA, because you can have also false positive ELISA. And this Western blot is able to confirm that the antibody detected by ELISA are specific, if you can observe either a band here at P40 or P60. Unfortunately, serology has also some limitation, because in some clinical setting, it can have a lower sensitivity, like in HIV-infected patients, for unknown reason. As I told you, it has a varying sensitivity by region, sensitivity and specificity. And of course, it is expected, but it has a lower sensitivity for cutaneous leishmaniasis, but it is quite high for visceral leishmaniasis. For cutaneous leishmaniasis, a lower sensitivity, however, if it is difficult to isolate or grow the parasite, or if you have a molecular test which can be sometimes inhibited, we have evaluated that for Leishmania guianensis in our centers, the sensitivity of the serology was as high as 66%, which shows quite unexpected. Another drawback of the serology is that it does not distinguish active infection and asymptomatic infection, of course. For example, it is not a good way to screen patients in an endemic area, because you cannot know if they have been reinfected after a successful treatment when you test them some years after a first infection, because the serology using RK39 can remain positive for several decades. So that's why there are ongoing efforts to find new antigens, which would be more specific of successful healing of the patient. A recent study conducted through two networks, the ESCMID, European Society of Clinical Microbiology and Infectious Disease Parasitology Study Group, and the Leishman Network. This study has been conducted last year, but it was an actualization of a previous study conducted in 2017. And you see that the serological test used in European countries, shown here on this map, have greatly evolved over years. And now ELISA assays are more and more used together with Western blot as a confirmatory test, but also RK29 RDT are also more used in some countries. Well, now a few words on the parasitologic diagnosis, because it is important to confirm infection and samples if you have cutaneous leishmaniasis. Samples consist in scraping the lesion, either with a lancet or a punch or a brush. A brush is very used also. Some use a syringe. So it's important to make this sample at the periphery of the lesion. And for visceral leishmaniasis, the preferred samples are whole blood of bone marrow aspirate, but it's also possible to, according to the clinical lesion or setting, to search Leishmania on gut biopsies, liver biopsy. Some use spleen aspirate of biopsy and lymph node aspirates. But in Europe, we are not very keen with spleen aspirate because there is a risk of hemorrhage due to low platelet counts if the disease is advanced. The first examination is a microscopic examination, but it can have a sensitivity of only 50%. So you can miss the parasite if the parasite load is not very high, or if the sampling has been difficult on a biopsy or on a cutaneous lesion, for example. The aim is to find those amastigotes in the phagocytic cells, as shown here, after Meg-Grunwald-Giemsa staining, usually. So the other methods used are the culture. It can have a high sensitivity from about 80–90%. Various medium can be used depending on the lab habits, of course, but also depending on the origin of the Leishmania species suspected. And for example, to grow Leishmania species from South America, RPMI medium is widely used. But PCR is the gold standard now for diagnosis because it has a high sensitivity. Two different DNA targets can be used. KDNA target is the preferred one to diagnose species from the old world. So for European patient where we suspect Leishmania infantum, it is a very good target. But it has a lower sensitivity to amplify species from the Americas. So in that instances, if you have a patient who has traveled to South America and has a cutaneous lesion, it is important to use a 18S target, for example, which has a better capacity to amplify those Leishmania DNA. Of course, PCR can be performed on any sample type. This is a picture showing on the spleen biopsy here. It's not so easy to find the Leishmania amastigot, which are very tiny inside the cells. And on histopathology, it's not always easy to make the diagnosis. Here is also a result of the recent European study. You see that the various techniques used by the participating centers were direct examination, of course, in the majority of labs, but only 26% have a facility to grow Leishmania parasite, but PCR is performed everywhere. And for Leishmania, for visceral Leishmaniasis, bone marrow is a preferred sample used, but whole blood, it's interesting to keep in mind that if it's difficult to perform sternal aspiration, bone marrow, due to bleeding, for example, of the patient, whole blood is very suitable because the sensitivity is almost equivalent as bone marrow aspiration. Well, it's good to have a positive PCR and make the diagnosis, but it's very important to have also the species identification to guide treatment. So for this, several techniques are available. Either DNA sequencing, or this was the reference method, the multi-locus enzyme electrophoresis, but now it is reserved to reference centers because very uneasy to perform. PCR RFLP is a possibility, and mass spectrometry by Malditov now can be also of help. So the interest is, of course, to have an actualization of the epidemiology, but for clinical reason, it is important to guide the treatment because you have several options available regarding American species. A simple identification method is the use of Malditov, but it is only possible if you have grown cultures, parasite in cultures. So it's not directly usable on a sample from a patient. So it needs to have the culture, but the results is rapid once you have the culture, and relatively accurate, except for Leishmania brasiliensis complex species. So it means that if you have a patient coming back from South America, it's not really, it will lead to a rough identification and you need to have more accurate methods. So this has been shown in this study here, comparing Malditoff to the reference method MLEE. And you see that regarding this complex of the species, there has been a quite high number of misidentification between Braziliensis, Guyanensis, Panamensis, and Peruviana. So this means that it's a problem when you have to choose a treatment for the patient. In this European study, dating now 10 years back, it was a comparison of identification methods across 16 European centers who are using PCR RFLP, sequencing of mini-exon, or sequencing of HSP70. And you see clearly that particularly ITS1 RFLP combination led to misidentification or numerous vague identification at a subgenus or a complex level, which is not enough for clinical guiding. And across the 16, the many centers who participate to the recent study last year, you see that molecular sequencing is adopted in more than 50% of centers. Only a few ones use Malditoff. And for example, in my center, we first try Malditoff, but we always performed in parallel the sequencing of HSP70. But the interest of Malditoff is the rapidity to obtain the result. But now the preferred methods in Europe seems to be HSP70. So why is it important to have the species? Depending on the species, you will have to choose several options for cutaneous leishmaniasis treatment. Either no treatment, wait and see, because it can lead to self-healing with minimal scars. So depending, or you could choose topical treatment or systemic treatment, and the choice of the treatment will depend on several factors. First, the localization of the lesion. If it is on the face and near the eyes, for example, it can have cosmetic or functional issues. So you have to choose an option for a best outcome. It will depend also on the size of the lesion, the possible relapse of another lesion previously treated, the diffuse cutaneous leishmaniasis setting, and the risk of mucosal leishmaniasis, of course, if the patient is returning from an endemic area and you don't have still the identification, or you have the identification and you can suspect that there could be a mucosal setting later on. So very important to have the identification. And here on the consequences of the cutaneous leishmaniasis, I show you a study that we conducted in our center in Rennes, where all patients diagnosed and treated at our consultation have been contacted years after their treatment, or at least 1 year after treatment. We have conducted a re-evaluation of the outcome and of the scars. And the scar has been quoted as invisible, minimal persistent, or persistent disfiguring scar, as observed here on the pictures. And you see 20% of patients have invisible lesion after treatment, but 1/3 had persistent impressive scars. And those scars were due to either South American species such as Leishmania guyanensis or Brasiliensis, or to Leishmania major. So those species were shown to be associated with those poorer outcome and poorer treatment, notably with some cases of relapse after treatment with Leishmania guyanensis, as observed here. After an initial cure of the first lesion here at the center, a month later, there is an appearance of new lesions at the periphery. So this is a typical picture of recurrence or relapse after initial cure. And those cases have been described to be more often associated with Leishmania virus. So Leishmania RNA virus is a virus infected the parasites and which amplify the inflammatory response due to the Leishmania infection. And in that cases, there is a more disfiguring scar, but also a higher number of relapse after treatment. And now Leishmania RNA virus has been described not only in South American Leishmania parasite, but also in Leishmania major, in Leishmania infantum, and so on. So it's more and more recognized as a possible prognosis factors in human infection. I will finish with a few epidemiological data. Sorry, I'm a bit late, but our colleague Carla Maya and colleagues have recently published a very nice paper showing actualized data on Leishmaniasis in humans in Europe, but also in dogs. And the main endemic areas, of course, are Spain, Portugal, Italy, and Greece. In France, we have many cases in the south of France, in Corsica. That's why those areas are monitored. But we have, above all, many cases diagnosed in French Guyana or imported cases from this area, because we have a military contingents who are sent for missions in French Guyana, and they regularly come back with Leishmania guyanensis or Leishmania brasiliensis infection. So a burden of Leishmaniasis in Europe, which is not well evaluated. As I told you, it is mainly unreported, but for example, in this study conducted through the Leishman network, we collected all European cases diagnosed in our centers. And you see that patients had been infected in various areas in the world. And these cases were mainly cutaneous leishmaniasis and mainly travel-related. But we have also, of course, many autochthonous cases due to Leishmania infantum. For Leishmania donovani complex, including Leishmania infantum, you see that as much as 40% of cases were CL cases, which is so not so unusual. According to WHO, there could be more than 8,000 cases diagnosed in Europe, and various very heterogeneous cumulative incidence has been also pointed, with a highest incidence in Albania, as shown here. And most interestingly, peaks of infection has been observed in Greece and Spain. And with different setting. In Greece, it is mainly an increasing over time, with a rise in immunocompromised patients from 9% to 25% from 2004 to 2018. By contrast, in Madrid, there has been an outbreak well described around 2010, with several hundreds of cases or so. VL and cutaneous Leishmania cases, and interestingly, a very high increase of incidence from 1 to 22 per hundreds of thousands inhabitants, and this has been explored, of course, and has published to several interesting papers with epidemiological exploration of this outbreak. Interestingly, there is no significant rise in canine leishmaniasis during this period. And these cases were due to an outbreak due to the environmental change in a park in the heart of the city of Madrid, a new urban park where hares proliferated and was the main reservoir of the parasites. And you see it's an epidemiology which is very different from the Greek situation, where the vector is not the same, the reservoir is not the same. The incidence, it was a peak in Madrid and a progressive rising in Greece, very localized in Spain and widespread in Greece and so on. So it's very important to monitor all those epidemiological parameters. And I will finish with this. The species identification, the surveillance is essential, is a moving landscape or important, but also autochthonous cutaneous leishmaniasis. And there has been recently a paper alerting on the possible spread of Leishmania donovani and Leishmania major from the east to the west of Europe. And with epidemiological changes due to the climate change, the modification of agricultural or forestry practice, it's important to monitor if it will affect the sandfly distribution. And if possibly, there could be an import of new Leishmania species or a spread of Leishmania species, possibly brought by a migrant, for example, or the expansion of new reservoir. So the importance of vector surveillance is crucial, and I will end with this. Thank you for your attention, and sorry, I've been a bit long.
No, Florence, it was like super insightful and in detail, very interesting, like to see where it's located, to like the infection and recognition of this infection, the sampling, and then treatment, which is not so easy. According to this webinar, there is like different species, different treatments, and Jessica Robbins knows all about it because she has been experiencing these struggles firsthand. So maybe I'm gonna leave the floor for Jessica so she can explain how she struggled with this and what to do, what don't, and also what carried her to start the Leishmaniasis Advocacy Network. So let's share the screen.
Awesome. Thanks, Sandra. Hi, everyone. Thank you for joining today. And thanks for Florence for her great presentation before mine. I'm much less a scientist, more of a social scientist, but I will give it a good go at giving a good presentation, as good as Florence's was. So I'm going to be talking about how my experience with cutaneous leishmaniasis led me to starting an advocacy platform, and the role that we play in Europe as either researchers, medical professionals, advocates, or persons with lived experience. Thank you to CLIMOS for hosting me today to speak on Leishmaniasis Advocacy Network, and also just being great partners in what we're trying to achieve. We're a very small team, and despite how passionate we are, it's very hard to do things sometimes with very minimal resources. So always grateful for the possibility to collaborate. So next slide, please.
Can you see it in a presentation mode?
I can, yeah.
Okay. Thank you, Jessica.
No worries. So before I begin, it's really important for me to acknowledge my position and my privilege. I'm a white woman from the UK with access to healthcare, education, and global networks that many people affected by leishmaniasis do not have. I recognise that while I have a lived experience of cutaneous leishmaniasis, my experience is shaped by the structures of power that have protected me in ways that others might not have been. And yeah, for me, this is a necessary starting point. The disease disproportionately affects people in contexts of poverty, displacement, and marginalisation. It's often called a disease of the poor, but I truly believe that that phrase can obscure the injustice behind it. The systemic neglect, underfunding, and disempowerment of communities that are most affected. So today, I really want to be clear. I'm not here to speak for others, but to hold space with others and hopefully create more of a space for those voices to be heard and recognised. And whilst I'm going to share my story, this story is just one story of many, many persons impacted by this disease throughout the world. Next slide, please. So I'm going to briefly talk about my personal diagnosis and experience of leishmaniasis, the issue of misdiagnosis, the lack of awareness, and also the impact on not only my story, but of what neglect of leishmaniasis means for us all globally, and how this has sort of shaped the development of the advocacy network. As many on this webinar will now know already, thanks to Florence, cutaneous leishmaniasis is a skin infection caused by a parasite that is transmitted by the bite of a female sandfly. There are over 15 different species, and despite being non-fatal, has huge impact on affected persons' lives. Next slide, please. So these are some photos of me. My journey with cutaneous leishmaniasis began after returning from a trip to Mexico. For 6 months, I experienced unexplained symptoms. The first lesion you can see on the far left appeared as a small spot on my skin that didn't heal. It kept growing, and eventually more lesions appeared on my arm and my ear. At first, I was in the UK and I went to 2 doctors in the UK, and both of them told me that I had anxiety. They were very early stages of my lesions, so very small spots. And then gradually they grew. By then I had moved to the United States. And again, the misdiagnoses continued. One dermatologist tried to freeze my lesions. Another gave me a steroid cream. I was told it could be skin cancer at one point. And then, the most common one was that I was told it was all in my head, that the lesions were spots connected to anxiety, and pretty much was just given the instruction to work on my mental health and come back if anything developed. And so the symptoms didn't go away. They progressively got worse. And these photos here show a timeline of around 7 months of lesion progression. I will say, though, by the 3rd picture, August 2023, I had a diagnosis by then, and my treatment started the month after then. And yeah, I had treatment in September, where that last photo is. So, this isn't an uncommon experience. Like many patients with cutaneous leishmaniasis, I encountered profound lack of awareness from healthcare providers, misdiagnoses, delays in diagnosis, conflicting treatment advice, and this sort of labyrinth of uncertainty revealed a really difficult truth and troubling, and that our healthcare systems really are unprepared for neglected diseases, and much more awareness needs to be made about them, including cutaneous leishmaniasis. And so eventually, as I just said, I received a definitive diagnosis. This was after my dermatologist finally taking the biopsy of my nose. That was around May 2023, so the second photo. And he called me back 2 days later, informing me that I was the most interesting case of the month, and referred me on to an NTD clinic in Vermont, who also actually had no idea what action to take. They didn't know my species, and at the time the CDC was refusing to test species, or taking over 6 months to respond to patients. And I still know patients in the US that still have never had a response from the CDC. And in fact, I had many ignored emails to the CDC. So that was the situation in May of 2023 in that picture. And at the time, I was told I'd probably have to have amphotericin B, which actually wasn't the correct course of action, and not what I ended up having. And also, I was quoted $11,000 to $52,000 for treatment because I was uninsured at the time due to visa difficulties and I couldn't access any of the state benefits. And so that financial burden led me to search for alternatives. And then eventually, I was very lucky that I found a clinical trial at the NIH in DC. And so that was the only way I could really access treatment without going into medical debt. And of course, that wasn't the only thing I was dealing with at the time. As my body was showing the visible signs of disease, I was met with stares, a lot of avoidance, many theories about what was wrong with me. I avoided photographs, I mentally withdrew. And again, I must emphasize that whilst I acknowledge my privilege, there is really something about being a woman and the beauty standards we're held to and the impact that has on someone who has already had to deal with sort of those insecurities her whole life. And so the feelings I had at that time with going into medical debt, what was happening to my face, it felt really overwhelming. There was a lot changing, like physical, mental health. I didn't have a good support network around me. I was in a new country. And so I came to understand something much larger, really, in that Leishmaniasis is not only a neglected tropical disease, but also a completely neglected human experience. It's much more than what it is as a biomedical disease. There are so many social aspects. And that neglect isn't limited to one region and one story. And everybody has a different story to tell and has a different impact. Next slide, please. And so, there's a common misconception is in that Leishmaniasis has historically been seen as a disease confined to tropical or subtropical regions. But as Florence indicated, that framing is becoming outdated. The reality is that we know Leishmaniasis is a climate-sensitive disease. And with climate change, sandflies, the disease vectors are expanding into parts of southern, even Central Europe. But it's not just the climate either. I think it's really important to talk about migration playing a critical role. Have refugees, asylum seekers, and seasonal laborers from endemic regions that may arrive in Europe already exposed or infected, but they're often left untreated due to systemic neglect. Legal status can restrict access to healthcare, language barriers, fear of deportation, and institutional racism as well, further deepens the exclusion. And I think European health systems frequently lack the diagnostic capacity and awareness to identify the diseases like CL and reinforcing the cycle of misdiagnosis and stigma. And so, it all goes back to a wider structural injustice that reflects whose health is deemed visible and whose is ignored. And so I really believe that Europe and, North America, where my story originates, has a responsibility to act because not only is the disease appearing in new regions, but our systems and our policies are deeply entangled with global neglect and a neglect that has had an impact on endemic regions for far too long now. We need to anticipate, we need to respond, we need to collaborate because climate really affects us all. And the spread of leishmaniasis is just one small example of how public health is being reshaped globally and the world in general. And so, I think another challenge that has arisen recently is states have become more protectionist and the architecture of global health financing is changing, such as in recent months for the worst in a lot of cases. And our role in advocating for collaborative health action becomes even more crucial. These sort of isolationist trends and subsequent policies undermine our ability to share information and resources and solutions. And, in a heavily globalized world, the health of one region inevitably affects the health of others. And so, at a minimum, we should be pooling our expertise and our technology and funding against and in a unified front against NTDs like leishmaniasis. And so it's also true that with its advanced healthcare infrastructure, Europe and also North America has a moral and practical obligation to support regions where healthcare access remains limited. But we also have an obligation to center the voices and the knowledge of those in endemic countries because there is so much knowledge there held and to be learned from. And it is a complete privilege for us to do so. And so, that involves us shifting the narrative. So raising awareness of leishmaniasis in Europe and North America so it's no longer invisible to us and telling, people here that it exists and, it's going to affect us all and recognize that they're deeply social issues tied to poverty, migration, colonial legacies and systemic health inequities. And so out of that experience and these thoughts came a desire to challenge the invisibility. Next slide, please. In 2023, I founded the Leishmaniasis Advocacy Network. It started as a LinkedIn post to my network. I've been in sort of the public health world since I was about 18, and I knew that was a good place to sort of post the photo of my lesion initially and sort of get conversations going, and started. At the time, I also felt really disillusioned by the amount of misinformation and disinformation on the internet. There are a lot of Facebook groups out there for cutaneous leishmaniasis that are full of some of the wildest things I've ever seen. And I felt, there was a lot of confusion and fear. And, as someone even from a public health background, I was quite panicked. And so LAN is aiming to be a platform that amplifies the voices of those with lived experience, to try and foster sort of a global collaboration and advocate for policies and research that center the most affected. We want to tell the stories that are overlooked and to drive meaningful change through collective action, predominantly focusing on CL, because there's a non-fatal version of leishmaniasis that requires stories to really fully understand the depth and the impact of the disease. We're sort of based on the hope that when persons with lived experience speak or given the platform to use their power, systems are more likely to listen. And when systems are more likely to listen, we can hope that important change begins to happen, although I do recognize that that is a simplified reality. My personal journey, one of confusion, isolation, misdiagnosis, and ultimately, I hope that people think empowerment reflects a wider story, and the story of thousands living with neglected diseases whose experience are completely dismissed, whose treatments are inaccessible, and whose pain is often unseen, and often stories that are way more profound than the one I've told you about my own today. And so, we're a team of 3 with many people working with us on the side, but we really believe in resilient and equitable healthcare systems, and to call for a lived experience in policy making, and to raise awareness about the diseases that don't just dominate the headlines, but for those that don't, and really to focus on the social justice aspect of it all. Next slide, please. And so when we talk about NTDs like cutaneous leishmaniasis, data plays such a critical role. I totally understand that. But I also think that data doesn't necessarily give us the depth of what we need to know. It tells us the what, but rarely the who, and certainly doesn't show us how it feels. And so storytelling for us becomes really essential. It's what the data doesn't capture. It's the psychological impact, the stigma, the way that it disrupts your identity. The stories of so many speak to the lived reality of leishmaniasis, and that's not just medical, but also social, emotional, and deeply political as well. And so we hope that when survivors share their experiences, we can do more than just raise awareness, but also make it very real to those who have never heard of it or experienced it. Storytelling is, the heart of human existence. It creates emotional connection, it invites empathy, and that's what we believe can motivate change. And so that's why Leishmaniasis Advocacy Network storytelling is sort of the core part of what we want to do. Disrupting the traditional top-down models of global health, less so subjects of study, becoming more knowledge holders and leaders and advocates. And so, the voices don't just add meaning, they add also accountability to those who need to make the changes in our society. These are very urgent and political, personal issues. Next slide, please. So this is just a few pictures of what we've been up to so far. We've begun building momentum, although, like I said at the beginning, it's very difficult. We're a small team with no resources. With shifting funding landscapes, it's been very difficult. But in March this year, I attended the WHO Global Meeting, the WHO Global Meeting on Skin-Related Neglected Tropical Diseases in Geneva, where I represented LAN and joined a growing coalition of persons with lived experience from around the world. I was really hoping to meet others with lived experience of CL there, but unfortunately, I was the only person with CL who attended. But I was lucky to meet the amazing people in this photo shared here. So it's Mulukat, Emmanuel, Matthias, and Rajni, and they're all persons with lived experience of skin diseases as well. And our aim is to hopefully push for stronger integration of the voices of persons with lived experience in global health policy making, and to get more people at those events, and to be together in the same space, because so much can happen in person in a shared space. It's great to connect over the internet, but I think there's just a difference to actually being together in person and having conversations together. And then the photo on the right, that was when we collaborated with researchers at Durham University, namely Paul Denny and Mags Layton, on a trip to Morocco, where I helped contribute as a lived experience advocate. As part of that work, I contributed to the coalition of global researchers in the NTD Global Network team, including from India and Brazil. And so that was to inspire the production of some educational animations to raise awareness of cutaneous leishmaniasis in endemic communities, which will hopefully be hosted on the LAN website. And then also I have to speak about our work with CLIMOS. We've offered some lived experience perspectives on CL, and we're reaching out to hopefully get more of those to work in collaboration, and, you know, sort of advocate for increased awareness and interest in NTDs from a climate perspective, as well as a personal aspect, storytelling aspect. And so, yeah, it's been really difficult to get this work going, but, you know, we've had some really great small milestones achieved, and we're hopeful that each small action propels us forward, and we're able to keep continuing just these small bits of work on the side, because we all work our 9-to-5s as well, and hopefully continue to share the stories and knowledge of those that this disease affects. Next slide, please. And so with that, I open to discussion, but I would just like to emphasize that LAN is completely collaborative. So I welcome feedback, suggestions, anybody has ideas. I welcome it all. And yeah, thanks so much for listening. It's been great.